So using weight loss to achieve health gains is the objective that we would like to achieve. But to do that, we first have to understand what patients would like and what their preferences are before we move forward. My name is Carl Leroux. I'm an obesity physician, and my interest is to understand how we can treat this disease to help patients achieve health gain. So the purpose of today is to introduce you to the options that is available, to introduce you to a team of multidisciplinary members that work on this challenge, and so then to ask you what your treatment options and preferences would be. Now, what treatment do you prefer? I think we have to start by saying that we need to manage and control chronic diseases better, but that we cannot achieve that by curing these chronic diseases, but we need to manage them in the long term, and therefore chronic treatment is very much required. Now, this is specifically important when we think about complications of diseases and diseases such as type 2 diabetes, chronic kidney disease, or liver disease, because the treatments for these very often overlap, and therefore the benefits can really be enhanced by a strategy that we may put to you to really understand what are your preferences and where do you like us to go. Now, weight loss for chronic illnesses is a new idea. And what we now want to have is intentional weight loss, meaning that we set out to achieve long-term weight loss that is sustainable. And we can do this by using nutritional therapies, by using pharmacotherapies, and also by using surgical therapies. Now, all of these options are equally valid, but what you prefer is the question that we now would like to address. We start from the principle that obesity is a chronic disease. And in fact, overeating does not cause obesity, but obesity as a disease causes people to overeat. And this disease is not your fault. And because it's not your fault, it means that we can move directly to finding a treatment that is going to work in the long term. Now, we work as a team, and any hospital will have such a team where we will have internal medicine doctors, we will have dietitians, we will have psychologists, we will have surgeons, because together we are able to achieve a better outcome for the patient. Now, you're going to be asked to consider three options. Option 1 is a surgical therapy. Option 2 is a pharmacotherapy or a medication. And option 3 is a nutritional therapy. Now, all of these options are equally helpful to patients, but some may have higher risks and others have more benefits. And therefore, we would like to understand where your preference lies so that we can build future systems that will be fit for purpose and work for you. But underlying all of this is the idea that obesity is a disease. Now, it is a disease of the part of the brain highlighted here that you and I don't have control over. So this middle part of the brain, the so-called hypothalamus, you and I cannot think ourselves less hungry or think ourselves more satisfied. This is controlled by this part of the brain, and that's why if this disease affects this part of the brain, it is not your fault, but it remains your responsibility, because we have to find a treatment that can effectively treat this disease at its origins. Now, that is challenging, but we are getting better all the time, and we are going to become more successful. For a long time, we thought that obesity was a disease of the outside of the brain, this part that you and I use for thinking and doing mathematics and controlling our behavior. But we understand that there's not one nerve cell in the outside of the brain that controls hunger or controls fullness. And again, we come back to this idea that this is a disease, but it is not your fault, but it is your responsibility to make a decision about what treatment is going to be the right one for you. So I'm going to summarize and say that obesity is a complex disease of the brain. It has an enormous impact on you as an individual, on the healthcare systems and the hospitals where you work and where I work, but also it has an impact on wider society because this disease is not fully understood and we need to change this. But with sustained weight loss in the long term, we can really address the complications of obesity and stop these from happening or even reverse them when they have happened. But we need to have realistic expectations about what is possible. And therefore, we're going to explain these treatment options to you so that you can understand what works and what doesn't work maybe for you, and what risks would you like to assume and what benefits you would like to achieve. Now, what we also understand about obesity as a disease is that it is very complex. But there is this biological domain, this area of biology where we can really intervene in. And that is where we as healthcare professionals have expertise, and this is what we will focus on. Because if we fix the biology, then all of the other components become much easier to handle. It doesn't make them less important, it just means that the biological determinants of this disease can be addressed effectively at the moment. But one of the major issues that we face in our society is stigma. And it's not only that people in society look at people living with obesity and stigmatize them, we also find that people who are living with this disease stigmatize themselves. And therefore, there's a barrier in them accessing care. Now, we want to break this down because stigma is not helpful in any disease process. It's never been shown to be helpful at managing people. And even if you beat yourself up because you think this is your fault, it's not helpful to you or to the healthcare system because we have to work together, destigmatize this disease, and allow us to treat this more effectively. So what do we want to achieve? We want to achieve health gains, not thinness. We want to use behavior therapies together with our biological therapies to amplify the benefits that we have. Now, we can do this as part of groups or as individual care, and it's important to say that there's no psychological issues that prevent anybody from accessing care or having interventions. So we work in a way that allows us to optimize the psychology to get a better result in the long term. Of course, there are many challenges that we face. These includes that getting used to actually losing a significant amount of weight. That's not easy, living in a body that is changing. Old habits die hard. And if we don't change the biology, it is almost impossible to force people to live in a way that they are not accustomed to or that they don't wish to live in that way. But therefore, planning remains an important part of how we move forward and how we think about this. But constantly we come back to this idea of resetting the setup. And if we don't succeed, we just go back to basics and start again. We will not ask people to be better citizens. We will not ask you to, just eat less and move more. But what we will ask you is to come to us if there are challenges so that we can address it. Now, early success can lead to long-term issues. And of course, relapse is part of recovery. So we expect for people to regain some weight during their journey, and therefore we use multiple treatments to address that effectively. Coming back again to the principles of what we are talking about, this disease is not your fault, but it is your responsibility. And when we think about the word responsibility, we can also break it down in whether or not we have an ability to respond. And that is another challenge. And therefore, working together and allowing the multidisciplinary team to support you will be very important for success in the long term. So what are the psychological possibilities? First of all, we have to start with this idea of radical self-acceptance at any weight. Weight will not be the way we will measure success. Rather, we use intentional weight loss to gain health. But you have to be able to accept yourself at the weight that you will be. And that may not be where you want to be, but it will be the so-called best weight that can be achieved. A commitment to health, and I strive for progress, not perfection. And responding again and stopping self-blame will be an important part of this journey. And we are here for support, and you are able to ask and find support when needed. But finding your unique path of feeling better, and lots of people tell us that all that they would like to achieve is to feel normal. And I think that is something that may now start to become possible. And this is a famous quote from Chumbawamba, an old pop band that says, "I get knocked down, but I get up again. You're never going to keep me down."
Hello, my name is Helen Heenahan. I am a bariatric surgeon at St. Vincent's University Hospital, and over the next 10 minutes, I'd like to mention what bariatric surgery is, how it works, its benefits, and its risks. So bariatric surgery involves operating on parts of the gastrointestinal tract to try and alter both the shape or route of GI content, and in doing so, it can help to achieve significant weight loss, but also many other health benefits. So bariatric surgery has been proven to be a very effective method for achieving weight loss over the past 50, 60 years. But in particular, one study that I'd like to mention to you called the Swedish Obesity Subject Study, the SOS study, has provided us with long-term data that supports how effective bariatric surgery is, particularly for weight loss, and shows how much weight these operations on the gut help patients to achieve who have extra weight to lose. So if you look at this graph here, what the grey line on top shows is people who had obesity, the disease of obesity, but did not have treatment for it. So they were managed in their GP practices without any of the other obesity treatments you'll have heard about today. The other three lines represent different types of bariatric surgery. One is a gastric band. The other is a gastroplasty, which involves similar to removing about 2/3 to 3/4 of the stomach. And the third green line represents a gastric bypass, which is one of the most effective bariatric surgery interventions. And you can see the dramatic weight loss that can be achieved over 20 years with the three surgical options, which is as much as 25 to 30% of someone's preoperative body weight, whereas patients who did not have any surgery but had obesity did not lose a significant amount of weight over a 20-year period, as you would expect. In fact, many gained a small amount of weight in that time period. Whilst many patients who want bariatric surgery wanted particularly to lose weight, we've noticed over the last 20 to 30 years that the greater benefits of surgery are the health improvements that it can lead to. So as you've learned by now, many organ systems in the body are affected by obesity. So obesity is linked to and can cause directly type 2 diabetes, heart disease, and chronic kidney disease. It also causes fatty liver disease. It can affect breathing through causing sleep apnea or other lung diseases, and it can affect your quality of life significantly. We know that obesity shortens people's lives. It can shorten it by as much as 8 to 9 years based on most recent evidence. Bariatric surgery can put into remission or improve all of those health problems that are caused by obesity. So for patients, for example, with type 2 diabetes and obesity who undergo bariatric surgery, 85 to 90% will achieve a significant improvement in diabetes or even a remission where blood sugars could completely normalize without treatment, and that could last into the long term. Chronic kidney disease can improve by treating obesity complications of diabetes and high blood pressure as well. So every organ system in the body benefits from weight loss, and typically the more weight that's lost, the better the benefits to your health. But bariatric surgery works in ways other than losing weight, and this is how it impacts health more significantly than some other treatments like nutritional therapies or medical therapies. Furthermore, bariatric surgery reduces the risk of cancer forming by about 40%, particularly cancers that are strongly linked to obesity, such as breast and womb cancer in women and colon, prostate and pancreas cancer in men. But almost every cancer is linked to obesity, and therefore losing weight helps to prevent it. Bariatric surgery can lengthen people's lives. Just like obesity shortens it, bariatric surgery can add those years of life back when somebody undergoes these operations. So one may ask, well, who is suitable to have bariatric surgery? If you've never considered it as an option, treatment option for you before, you might wonder whether you're a potential candidate for it. So listed here are the indications for bariatric surgery. So this is where the benefits of surgery outweighs the risk of surgery. So that occurs when the BMI, so that's the relationship of your weight and your height, is over 35 and you have an obesity-related complication such as diabetes, liver disease or kidney disease. If you don't have any, if a patient doesn't have any health problem related to obesity, then a BMI over 40 is also an eligibility criteria for bariatric surgery. So it's also important that patients have previously tried to lose weight without bariatric surgery, so through using diets, exercise, or indeed medications for at least 6 months, where those treatments have proven not to help you lose a significant amount of weight. It's also important that someone understands what surgery involves and the risks of it, because whilst it might be the most effective treatment for obesity, it certainly carries a few greater risks than the other treatments of diet changes and taking medicines. It's also important that if someone is considering bariatric surgery, that a patient is committed to undergoing the right preparation for it, which involves being evaluated by the multidisciplinary team, including the clinician, the dietitian and the psychologist, as well as the surgeon. And that follow-up after surgery is with that MDT is equally important. So bariatric surgery, there are a number of bariatric surgery procedures one can do, but there are two that are particularly effective and come at the lowest possible risk for these surgeries. They are the sleeve gastrectomy and the gastric bypass, and I'm going to mention those two in a little more detail in a moment. But I will just say before that all of these operations are completed laparoscopically, so that means by keyhole surgery. The length of time in hospital is quite short for these operations, although they carry a small risk, and that risk is very low and the recovery is quick after these surgeries. So a patient is typically admitted on the day of the surgery. The surgeries last between 1 to 2 hours typically, and patients are typically ready for discharge, if not the next day. 95% will be discharged on the second day after surgery. So quite a short hospital stay. So I'll mention the advantages and disadvantages of the two commonest bariatric operations, those being the sleeve gastrectomy and the gastric bypass. The sleeve gastrectomy is the most common bariatric operation performed worldwide at present. This is probably because of its simplicity and its great efficacy, but also because it carries very low risk profile. What the sleeve gastrectomy involves is removing about 3/4 of the stomach. So it's taken out of the body. It's quite a useless bit of stomach that offers very little benefit to having it. It's capacious and can hold quite a lot of food and fluid content and has very few benefits. In fact, this is the part of the stomach that makes us hungry. The part of the stomach that I removed during the sleeve gastrectomy makes most of our hunger hormone called ghrelin and a number of other gut hormones that signal to other parts of the gastrointestinal tract and are linked to our hunger levels and our feeling of fullness after we eat. So when I remove that part of the stomach, I immediately make people feel full and feel more satisfied when they eat. And that's partly how it works, rather than just making the stomach much smaller. So it's a very safe and very effective operation. Its advantages are that it helps people to lose between 25 to 30% of your current weight on average. Some people will lose a little bit more and some a little bit less, but on average the weight loss is about 25%, and it can take about 12 to 18 months to lose that weight, and then it stabilises for the long term. The operation helps, as I mentioned previously, to improve or even put into remission type 2 diabetes, fatty liver disease, and chronic kidney disease. It also improves all of the other obesity complications that I've mentioned, and it's a very safe operation. The safety of this operation, and indeed the gastric bypass, is very similar to undergoing a gallbladder removal operation, which would be considered quite routine. So the risk of not surviving the operation or the 30 days after is very low. It's less than 1 in 1,000. And the risk of a problem happening that might lengthen the hospital stay more than 2 days is less than 1 in 100. So 99 in 100 people will get through this operation safely and be in and out in 2 days with minimal the most minimal complications that one can expect from major surgery. The disadvantages of the sleeve gastrectomy operation are that it is irreversible. I've removed part of the stomach, and albeit that's a useless bit of stomach, I can't put it back in. So it's an irreversible operation. There is a risk of developing gastroesophageal acid reflux or acid reflux after this operation. It's low, and most people who have reflux prior to surgery, it will improve. So 80% of people who already have acid reflux, it will go away because of the weight loss that is achieved with surgery. But about 20% of people will still have reflux afterwards. And in some of those people, about 2 in those 20, it will get worse. But that is easy to manage with an acid medication, which reduces the amount of acid that stomach will make. It's also important after surgery that one takes a daily multivitamin, and that is for life, to maintain the best nutritional health possible. And because the only good thing the bit of stomach that I remove does is it helps to absorb vitamin B12 from your food. It makes a protein that absorbs B12, and when I remove that part of the stomach, you can't absorb that as well anymore. So we do recommend getting B12 injections into the arm every 3 months to keep B12 levels high. There's other ways of getting B12, but we find that way the most effective. There is a risk of weight regain after any of these operations, and it is between 15 and 20% with the sleeve gastrectomy. So obesity is as we know, it's a complex disease with many causes, and it is very hard to cure. I don't think it is a curable disease, but it is treatable. And so whilst this operation is very effective in helping people to lose weight, there is a risk that the weight can come back. But that does only happen in between 1 in 5 and 1 in 8 people. The Roux-en-Y gastric bypass is the other commonly performed operation both in Ireland and worldwide. It's slightly more complex than the sleeve gastrectomy, but as a result, the benefits of the gastric bypass are a little bit greater. So the advantages of this operation, in which I make the stomach smaller and also rearrange the small bowel so food takes a quicker path downstream, are that one can lose between 25 and 30% weight again. So you'll see the weight loss is very similar between the two operations, but it will be slightly closer to 30% with the gastric bypass. It also leads to significant health improvements and can lead to more people who have type 2 diabetes, liver disease and kidney disease having a remission or a significant improvement in those conditions compared to the sleeve gastrectomy and to other bariatric operations. And it improves every obesity complication, again, as I mentioned earlier. For people who do have acid reflux and for whom that is quite troublesome, the gastric bypass is a better operation than the sleeve gastrectomy. It's a better cure for acid reflux than the sleeve operation. So 98 to 99 in every 100 people who have acid reflux and undergo a gastric bypass, that acid reflux will be gone for the long term after the gastric bypass. Unlike the sleeve gastrectomy, the gastric bypass is a reversible operation. I don't remove any part of the gut when I do a gastric bypass, I just rearrange it all. So you could reverse it, although reversing it can be difficult and is very, very rarely needed. The disadvantages of the gastric bypass operation are that it carries a surgical risk, just like the sleeve gastrectomy, but it carries an additional 1 in 100 risk that the bowel could block or twist or lead to a problem called an internal hernia that you don't get with the sleeve gastrectomy. So although that's a very small risk, it is an additional one. And those risks are very treatable, but they may need a second operation to fix them at any stage after the procedure. It's also important to take a multivitamin after this operation, and in addition, it's important to take a calcium and vitamin D supplement and an iron supplement to maintain the best nutritional health, because with the way a gastric bypass is performed, it does mean you absorb less nutrients from your food, and we need to give them back in the form of vitamins to maintain the best result. Additionally, after a gastric bypass, you need the B12 supplements 3 monthly. But again, that's standard after most bariatric operations. There is a risk of weight regain with this operation as well, but it is less than that with the sleeve gastrectomy. In fact, it's about half the risk with the sleeve gastrectomy. It's about 8 to 10% of patients who will regain weight after a gastric bypass. So again, one of the common fears people have when they're recommended any surgery, particularly bariatric surgery, is what is the risk of dying afterwards. And although it's not a nice thing to talk about, it's really important when people plan an operation, an elective operation, because that is one that you won't, it's not an emergency operation. But even though it's important and can lengthen life, it's important to understand the mortality rate, which is the risk of people dying afterwards. And these are very, very safe operations from a mortality perspective. As I mentioned, they're very similar to a cholecystectomy, which is gallbladder removal surgery. So that means the mortality risk is less than 1 in 1,000 for both the sleeve and the bypass. The risks that I mentioned that can happen after these surgeries are things like infection inside in the abdomen. So that could happen if there was a leak of gastrointestinal content from any of the staple or stitch lines at the time of surgery. And that might need a longer spell in hospital to fix, or even a second operation to fix it. But as I mentioned, the risk is less than 1 in 100. Similarly, there's a risk of bleeding with any operation, a risk of getting a clot in a vein in the leg that could travel to an artery in the lung. And there's lots we do during surgery and afterwards to prevent these risks from happening, including giving some blood thinning medication for a short period of time. And as I mentioned, with the gastric bypass specifically, there's a risk of bowel obstruction, which is a blockage in the bowel for different reasons, but they're very fixable. So I'll finish there. And again, summarise by saying bariatric surgery is a very effective treatment for obesity in achieving not just weight loss, but significant health improvements, and these are very safe operations.
If we think about medication options that we have for the treatment of obesity, what we can first of all need to understand is that these medications don't cure the disease. In fact, what they do is they can put the disease in remission or at least control the disease. But the minute we stop the medications, what you will see from this slide is that the disease relapses, the disease comes back. And we know that the disease comes back when the weight starts regaining. So many of us would like to take treatments such as medication for the purpose of curing the disease and then stop the medication and allow the weight to remain normal and constant in the long term. That is not possible. So the first thing to understand about medication is that if it works, it will only work as long as we take it. And therefore, this is a chronic treatment for this chronic disease. Now, the first option we have is a very old treatment called ORLISTAT. This is a medication that only works in the gut. It is not absorbed into the bloodstream, and therefore it has no side effects. But the way this medication works is it works by blocking at least a third of the fat that you eat. So if you eat a large amount of fat, a third of that fat is going to come out the South Pole. And that's going to cause terrible, terrible diarrhea. It's a type of diarrhea that people think they need to go to the bathroom and it's already too late. But you are in 100% control, because if you reduce the amount of fat that you eat, then there's not enough fat to come out the South Pole, there's no diarrhea, and because you've reduced the amount of fat that you eat, you actually lose weight in the long term. So ORLISTAT is a medication that is very safe because it's not absorbed. It is effective. About 1 in 3 people can lose 10% of their weight. And it does not have side effects, but the effects of the medication is such that it can be unpleasant if people consume too much fat. But we can work with patients to reduce the amount of fat in their diet and therefore stop this from happening. The second medication is 2 old medications that have been combined, and we call this combination Mysimba. It's a combination of Naltrexone and Bupropion. And by combining these medications, what they do, they work on that part of the brain that causes the disease of obesity and stimulate a specific nerve in the brain to make people feel less hungry and to allow people to have fewer cravings. Now, again, this only works in 1 in 3 people, and the weight loss is approximately 10%. Now, this medication also has side effects. The most important one is that people can feel nauseous in the beginning, but the nausea will subside and go away within a few days or a few weeks. Another problem is that people may have insomnia, trouble sleeping at night. So we only take these tablets first thing in the morning when you wake up and at midday, never in the afternoon and the evening, and that reduces the risk of insomnia. Now, it's a very rare complication, but those patients that have epilepsy cannot take this drug because it can increase convulsions. But if you don't have epilepsy, then typically these medications are very well tolerated. Finally, we have treatments called semaglutide or liraglutide. Now, these treatments are natural hormones that you and I have, but people that have the disease of obesity don't have enough of these hormones. So what we are now able to do is give these natural hormones back to patients. But because it's a natural hormone, if you swallow it, the stomach acids will break it down. And therefore we give it as an injection under the skin, either once a day in the form of liraglutide or once a week in the form of semaglutide. Now, if these medications work, it works by making people feel more full or more satisfied after they've had a meal. It works in approximately 1 in every 2 people, and the weight loss is about 10 to 15%. Now, the medications also have side effects, and the side effects include nausea in the beginning that will subside. Other people may have constipation, and if that happens, please let us know because we can manage that quite easily. And then finally, anything that makes you lose weight, be that a nutritional therapy, a pharmacotherapy, or a surgical therapy, can cause gallstones. This is no different. So maybe 3 in every 100 people can have gallstones, but if that happens, we can also manage those processes.
Hello, my name is Wardel Najim. I'm a clinical nutritionist. I provide nutritional therapy for the management of obesity and other chronic diseases, such as diabetes, chronic kidney disease, and non-alcoholic fatty liver disease. I'd like to spend the next 5 minutes explaining what nutritional therapy is and how we use it in our service for the management of the mentioned diseases. Who wouldn't have tried a diet at some point of their lives? In fact, unsupervised diet is the most common form of therapy most people will try to lose weight. It is successful in the short term. But the problem becomes when people stop losing weight and they hit a plateau. What happens is they stop the treatment, go back to their old habits, and regain all the weight they've lost. This is not what we do in nutritional therapy. Nutritional therapy focuses on providing a more structured plan of lifestyle and dietary changes. After a long discussion with each patient at the first session, we learn about patients' food preferences, what they like and what they don't like. Also, very importantly, we ask them about what they've tried in the past. People are experienced dieters. They would have tried things that worked for them in the past and things that didn't work. So we take that into consideration. With them, we plan a personalized diet and a personalized approach. They maintain it for at least 3 months, and during this time, patients will have multiple follow-up sessions, usually about 6 sessions, but they can be more if patients need more support. At the 3 months milestone, there is a weight loss review session. This review session will involve trying to understand whether patients are responders to the nutritional therapy or non-responders. They are considered responders if they lose about 5% of their weight. At this time, we can have a discussion with them whether they are happy with this amount of weight loss and they are happy to continue. Then they will need to have follow-ups for life. Nutritional therapy is not a short-term approach. Whatever patients start to lose weight, they really need to continue it for life. They are considered non-responders if they don't lose 5% of their weight at this milestone. So what we can do here is we can change the method, the nutritional therapy method. And there are so many methods to choose from. All of the methods that you see on the slide here, they will result in the same amount of weight. But it's very important to find what matches the person's need and their lifestyle as well. Usually, the first approach would be a personalized diet. We create a sustainable calorie deficit. There is no success if we make patients very hungry very quickly. So we make a sustainable calorie deficit. You would have also heard that obesity is a disease where patients feel hungrier than other people. So we use the nutrients to make people feel full. Many people think they know it all when it comes to nutritional therapy, but the reality is not. They don't know which nutrients make them feel fuller, which nutrients make them less hungry during the day, and that's our job to help them to achieve. So we will calculate their protein requirement and also educate them on how to meet that protein intake during their day. Some patients might prefer to use partial meal replacements, and we do encourage this approach. Some other patients might want to have some restrictive hours of eating, and that is called intermittent fasting, and we can also help them with that if that's what they want. Now, the very important question you are probably asking yourself now is, if I follow everything you're saying, how much weight loss should I expect to lose? On average, nutritional therapy provides about 8.6% weight loss at the 3 months time point. The longer term weight loss is what we actually try to achieve. So 50% of people, 1 in 2 people, will manage 5% weight loss at 1 year and beyond. And 20% of people, that is 2 in 10 people, will manage 10% of weight. These numbers are still very important. They might sound too little, but they are actually still very important, and they provide a lot of health benefits. They do provide a little bit of metabolic benefit, but patients usually who follow a nutritional therapy will feel much better about themselves, will feel healthier, will have more energy during the day. These amount of weight loss will also stop the worsening of chronic diseases such as type 2 diabetes, non-alcoholic fatty liver disease, and chronic kidney disease. But they may not be sufficient to improve these diseases as they require larger amount of weight loss. So to summarize everything I said, and your take-home message is that nutritional therapy is very safe, and you probably all tried a form of it at some point in your life. It generates moderate amount of weight loss of 5 to 10%. It improves general health and stops the worsening of chronic diseases, but it may not be sufficient to improve these diseases as they require larger amount of weight.
So in conclusion, we have 3 options that you can choose from. The first is nutritional therapy, second is pharmacotherapy or medication, and finally, surgical therapies. All of these therapies are equally valid, and whatever you choose is the right choice. And certainly, some people will say, I would like to start with treatment A, but I would like to move to treatment B later. Other people will say, I don't want treatment B at all. All of that is completely acceptable, and there's no right or wrong answers. But we would like to understand what you think at this point is the right treatment for you to start with. So the next steps are for you to consider the options, complete the preference form, send us feedback on SurveyMonkey, and Hilary Craig will be in touch to follow up with you and take this process forward. Thank you very much.